Presenting a short case with chest x-rays session and oral question.
Yes.
This patient is 39-year-old with shortness of breath, cough and expectoration, and he got a fever, been admitted for the last 2 days with acute exacerbation of his conditions. He is not a smoker and he is complaining of shortness of breath and sputum production since childhood. Clinically he is cyanosed.
Yes.
And because the hand is hot, therefore this is a central cyanosis. And he is also clubbed.
Yes.
And cyanosis and clubbing, when presenting in a single disease, the causes are 5. 2 cardiac, and 2 respiratory, and 1 in the liver.
What chance?
2 respiratory, widespread bronchiectasis as in this case, fibrosing alveolitis also, and 2 cardiac, cyanotic congenital heart disease, and SBE, subacute bacterial endocarditis. And the liver cause of cyanosis and clubbing in the single disease is liver cirrhosis with a shunt, and the shunt in the subpleural. The patients also have barrel chest.
رجع ايدك لورا شوية.
رجع ايدك لورا شوية. barrel chest ده من اللاترال منها. Using the accessory muscle for his respiration. He is lifting his shoulder, both shoulder lifting. He is anxious, طلع لسانك, cyanosed, central cyanosis, and he is using mainly his abdomen for respiration, which is normal in male. Therefore, this patient with widespread bronchiectasis, that's why he is producing a lot of sputum. He is not a smoker, as we say, and his condition is starting since the age of 2. Therefore, we consider this is a case of widespread bronchiectasis, and the most probable causes of bronchiectasis at the age of 2, what are they?
Viral infection, يعني like whooping cough, measles.
Yes. I mean, the most common site for bronchiectasis is due in the old days due to whooping cough and measles, and the mainly affected is the lower lobe, the left lower lobe. This is the commonest site of bronchiectasis in frequency. The second common site is the middle lobe. This is the middle lobe. In the old day where TB is causing what they call middle lobe syndrome. The third in frequency is the lower lobe, the right lower lobe. This is the right lower lobe. And the fourth is the lingula. This is the lingula. And then the right upper lobe, and very rarely you get bronchiectasis of the upper lobes. Left upper lobes. A sequence of frequency of bronchiectasis, the most common site is the left lower lobe, then the right middle lobe, then the right lower lobe, then the lingula, then the right upper lobe, and very rarely you get bronchiectasis of what? Of the left upper lobe, because the bronchus of the left upper lobe is vertically downward directed, and there is no stagnation of sputum. you see these cystic changes, these rounded cystic changes all over the lung. Most of the lung are involved. There is a slightly enlargement of the heart of the right side.
Yes.
And this is here the patient present with acute exacerbation of infection in his bronchiectasis. His sputum is green, he is short of breath, he got fever, he was at admission confused. Therefore, this is a bronchiectasis. Widespread bronchiectasis in this chest X-ray. And as we mentioned, bronchiectasis might be in the lower lobe, which is bacterial, and might be in the upper lobe, which is TB. Cystic fibrosis can cause bronchiectasis in the upper lobe, usually cystic fibrosis in the upper lobe. And because this patient presented with widespread bronchiectasis since the age of 2, therefore most probable causes is immune deficient, what they call it IgG deficient, 2 and 3 and 4. He gave no history of measles before or whooping cough before. Therefore, most probably this is a widespread bronchiectasis in this patient. Treatment is to treat the infection, give bronchodilators, physiotherapy, and we gave oxygen to this patient. His ECG, this patient is shown. This is ECG. You see, this is a P. pulmonale. P. pulmonale. P. pulmonale. P wave is peaked. P wave composed of two: contraction of the right atrium and the left atrium. P wave. The distance of P wave is usually 2.5 small squares. When it is peaked, we call it P. pulmonale, indicated that the right atrium is hypertrophied, indicating that the problem is mainly in the lung when we see P. pulmonale. While if we see P. mitrale, what they call it bifid P, this is the P. Or just like this. Two components of P. The first component represented the right atrium. The second component represented the left atrium. This is called P. mitrale, or we found it just like M shape, P. mitrale. While P. pulmonale is peaked. P. P. pulmonale, indicating that there is a lung lesion and there is hypertrophied of the right atrium. The best site to see P. pulmonale, the best site is lead 2 of the standard and lead 3. This is the best site to find P. pulmonale. Therefore, this patient got P. pulmonale. He got this is also a right bundle branch block with citrain, right ventricular hypertrophy with citrain, also high R in V1. You see, high R in V1. This is in V1 with citrain. Therefore, the heart being affected. That's why we get enlarged heart in this chest x-ray. This is the first case. Okay. روح التست روح على الأكل بس روح. هسه وقف التصوير. 5-year-old patient presenting with upper abdominal pain, right side upper abdominal pain, with tenderness in that area, and he got jaundice. He is mildly anemic, and he got this condition repeated and on and off since young age. What is the finding in this KUB?
موجود عندنا
Plain abdomen.
multiple gallstone.
Yes, there is a gallstones. You will find these are gallstones, multiple
عندنا spleen.
calcified gallstones,
Spleen.
and enlarged spleen is this. This is enlarged spleen. What is the formula of the spleen? The formula of a normal spleen is 1, 3, 5, 7, 9, 10, 11. 1 is the width. Sorry, 1 is the thickness of the spleen. 3 is the width of the spleen. 5 is the length of the spleen. And 7 ounces is the weight of the spleen. And he is belong to 9 ribs, 10 ribs, and 12 ribs. The spleen here is enlarged. Therefore, how we can join these together? Patient anemic, he got upper abdominal pain, right side, he got enlarged spleen. What most probably the cause?
ممكن spherocytosis.
Yes,
يعني كهيموليتيك.
yes, congenital spherocytosis actually, congenital spherocytosis. And the best treatment of this patient is what?
يعني هسه بالنسبة للجولستون يعني removal يعني
Yes.
بالنسبة لها.
If you send him for surgery, you shouldn't tell the surgeon remove this gallbladder for stones to avoid obstructive jaundice. You should say to the surgeon, remove these gallstones and what?
Spleen.
Remove the spleen. And the spleen, if we remove it, does it correct the picture?
Not correct.
It doesn't correct the picture. Spherocytosis is still spherocytosis, but there will be no hemolysis more,
Yes.
and there is no more jaundice, and no more anemia, and no more gallstones.
Yes.
Okay, this is congenital spherocytosis presented with acute abdomen, gallstones, and enlarged spleen.
Okay.
A patient, Noor al-Islam, her name, is 15-year-old female, presented with shortness of breath, and this is her chest x-ray. You find what?
Pleural effusion.
Yes, there is obliteration of the angle there on the lower part of the left side, and this is Alice line, what they call it, Alice line, S-shaped line. That's typical of pleural effusion. And what else?
Cardiomegaly.
Yes, there is a cardiomegaly. Okay?
Yes.
What is the cause of her cardiomegaly?
Pericardial effusion.
Yes, it was pericardial effusion. Therefore, this young lady, young patient, presented with a pleural effusion and pericardial effusion. She had arthritis, small joint arthritis. She had a hair falling. She had a mouth ulcer. What do you think this condition is?
SLA ممكن.
Yes, it was actually SLA presented with pleurisy and pleural effusion and pericardial effusion in this young patient. We aspirate that effusion. It was actually transudate and normal cell constituent. There is no lymphocyte predominant, is mainly polymorph predominant, and the pericardial effusion is also sent for aspiration. This is SLE with pleural effusion and pericardial effusion. What are the pulmonary complication of SLE?
يعني pleurisy, pleural
Yes, mainly pleurisy, pleural effusion, and what else?
fibrosis.
Pericardial effusion and fibrosis. All the connective tissue in general might cause pulmonary fibrosis in 25%. 25%. Okay. This patient is 40, complaining of cough and fever. What is the finding in this patient? He is a smoker. This chest x-ray, you see this chest x-ray showing multiple calcifications all over the lung, bilateral. With what? With a round shadow there, This is, what is this?
Nipples.
Yes, this is cornified nipple, because they are on the same level, on the same side, left and right, away from the periphery of the chest in the same distance, rounded, both of them rounded. And this patient is a nigger patient, black patient, therefore this is a rounded, cornified nipple of his breast. And these are, what are these?
Calcifications.
Yes, these are multiple gone focus in this patient of all tuberculosis in the age of, in the young age, and calcified. This patient is 20, repeatedly, 4 times per year, repeatedly with chest infection, and this is his chest x-ray. Actually, clinically, there is a pneumonia signs in this place. Pneumonia in this place. What other finding in this chest x-ray you see? You see this is a foreign body. Actually, it was a teeth. This patient got a car accident. He lost his conscious, and his teeth is lost. He actually is aspirated in the chest, and he got what? Repeated chest infection due to lodging of the teeth in the lower lobe. We actually did the bronchoscope for this patient, and we removed this all teeth, and the patient has become better.
نعم.
Sundus, female patient, age 50. She got shortness of breath and repetitive cough for the last 2 or 3 years. And this is her chest x-ray. This is her chest x-ray. You see this chest x-ray, there is a small volume lung. This is the first rib, the second rib, the third rib is attaching the diaphragm. And a normal chest x-ray, the normal chest x-ray, usually the fifth attaching the diaphragm near into the heart.
So 5th or 6th?
Fifth attaching near to the heart, and the sixth also attaching in the middle. Therefore, a small lung. What is the causes of a small lung?
Collagen vascular disease يعني.
Yes, fibrosis of the lung. This patient got cyanosis and clubbing. She had the repetitive cough. The first patient got cyanosis and clubbing. As we said, there are 2 causes of cyanosis and clubbing in the same condition, respiratory. One of them we presented is what they call it, widespread bronchiectasis. The second one is what? Pulmonary fibrosis. Pulmonary fibrosis, there are a lot of causes of pulmonary fibrosis. In this patient, it was actually idiopathic. Respiratory function test we did for this patient, it was restrictive. And this is her CT scan. CT scan is an instrument cutting the chest to many pieces. If you want a CT scan, usually the distance between the first and the second is 5 centimeters. If you want a high resolution CT scan, the distance become 1 centimeters. You mean a lot of picture you see. CT scan composed in this patient of two x-rays, two slides. This is what they call it is a window slides or mediastinal window, and this is the tissue face of the CT scan. It means the tissue face means the lung tissue appearing in this CT scan slides. CT scan depend on the density of the organs. The density of the air is 0. If you find density low, fat density is -15. Lung density is around up to 10. If pleural effusion is between 20 to 30. If you got a solid mass, just like liver, the heart density is high. Tumor in the lung is also density high, and its density will decide the lesion, what type of lesion, abnormal lesion we see. You see there is what they call this.
Bronchogram.
This is a fibrosis all over the lung. A honeycomb. Fibrosis all over the lung. Fibrosis all over the lung. Widespread, mainly involving the lower part of the lung. A fibrosis of the lung, mainly involving the lower part of the lung, is usually idiopathic. There is certain fibrosis. Sometimes you will get fibrosis involving the upper part of the lung. If the fibrosis involving the upper part of the lung, the differential diagnosis is what?
السنابل هو يصير.
Yes. Mainly involving the upper part. And fibrosis in alveoli mainly involving what? The lower part. In this picture, mainly fibrosis in the lower part of the lung, and it was actually idiopathic pulmonary fibrosis.
هو drug induced هم ممكن يصير باللور؟ drug induced.
If we find a fibrosis mainly involving the upper part, we write sanabel in Arabic. S for
Silicosis.
silicosis. Silicosis. Cystic fibrosis. Sarcoidosis. For this, and pneumoconiosis. Ankylosing spondylosis.
هاي هذا.
B. Berylliosis. L. Lympholeiomyomatosis. Okay?
TB ايش حجم مداخل؟
TB actually is a causative. If somebody asks you what is the differential diagnosis of this fibrosis alveoli, you mention TB. Okay? This is a definite disease, but usually these are syndrome, many causes fibrosis alveoli, and that's why TB is not considered in it, because it is cause malignancy sometimes mimic fibrosis alveoli. What they call this malignancy is coming from the abdomen to the chest. What they call it?
سكنتري صح؟
Yes, secondary in the lymphatic. What do you call it? Lymphangitis carcinomatosis. Therefore, this patient, this lady, she got what? Lower lobe fibrosis. Suppose this lady is what? She had a rheumatoid arthritis. What is the causes of fibrosis and alveolitis in rheumatoid arthritis? Yes, probably disease-induced and probably drug-induced. And how we differentiate between them?
High blood eosinophilia.
Yes, if you find eosinophilia in the blood is high, this is most probably drug-induced. If you find in the bronchial wash eosinophilia also high, this is drug-induced. If you find polymorph, this is disease-induced. This is a case of fibrosis and alveolitis presented with shortness of breath. Why we examine the abdomen in fibrosis and alveolitis?
ممكن احنا نفحص السبلين مالتهم.
We examine the abdomen in fibrosis and alveolitis to look for organomegaly, to exclude what sarcoidosis.
Yes.
But in every female presented with a chest problem, this is a rule. In every female, whatever her age, any chest problem, even a simple pneumonia, you should examine the breast and you should examine the legs for DVT. The breast for what? Malignancy. CA breast. While in male we insist on examination of genitalia and what? And the legs for DVT. It might be a pulmonary embolism, repeated pulmonary embolism. Therefore, this is a fibrosis and alveolitis. And fibrosis and alveolitis, what is the prognosis?
Poor prognosis.
Usually bad prognosis, yes. Usually bad prognosis.
Especially in idiopathic.
Yes, especially in the idiopathic. If we found a cause of fibrosis alveolitis, it's better to treat the cause. There is a 57-year-old male, heavy smoker, was presented with shortness of breath, cough, and hemoptysis. He is a club. And this is his chest X-ray. You see hyperinflated chest, you see?
Yes.
And chronic bronchitic chest. And what else? There is something there.
Yes, opacity.
As if it is an opacity, just like sun rays opacity there in this area. What could be this? Most probably what?
Malignancy, most probably.
Yes, most probably malignancy. Actually, we did a lateral for this patient and we found this chest X-ray, lateral chest X-ray, an interesting chest X-ray. You see this tongue projection? This is, they call it tongue projection of collapsing left upper lobe. Usually substernal in the chest X-ray, in this area usually is dark. When you see a tongue projection in this area, this is mainly due to what? Left upper lobe obstruction or collapse.
Yes.
Collapsing of the left upper lobe is rare unless there is a tumor in the main bronchus of that lobe. Usually collapsing is occur in the right, and because we say the duct of the left is wide and vertically downward.
صار بالنسبة هاي البروجكشن كلش كلير مالتها انه malignancy not regular.
I did the bronchoscope for this patient and it was undifferentiated old cell carcinoma. Sorry, differentiated old cell carcinoma. Heavy smoker.
Salam.